Good afternoon, everyone. At the outset, I would like to thank Haldipurkar sir for giving me an opportunity to be a part of this IC. So my topic for the day is presbyopic lenses. So as you know, the correction of presbyopia following cataract surgery with conventional IOLs requires the patient to use bifocal lenses or progressive lenses. Bifocal lenses comes with its own set of problems like image jump, lesser working distance, uncomfortable head position during work. Although progressive lenses gives a good intermediate distance, it has its problem with respect to restricted field of vision limited by head and eye movements for the horizontal plane and also the distortion when viewed sidewards. So there was always a need for presbyopia correction during cataract surgery. The options for presbyopic correction during cataract surgery include monovision, multifocal lenses, and EDOF lenses, which could be diffractive technology or wavefront technology. And the newer lenses are trifocal, quadrifocal, and EDOF multifocal combinations. So technology used in presbyopic correcting IOLs are refractive technology, which was used in older multifocals, diffractive technology, which is used in most of the modern lenses, including trifocal, multifocal, and EDOF lenses, wavefront technology, which uses the principle of altering the spherical aberration currently used in some EDOF lenses like mini-well and eye-enhanced lenses. So, when light passes through a stenopic slit or a diffractive gratings, the light deviates by an amount which is actually related to the step width of the diffraction grating. Narrower the step, higher the power. And the step height decides the light distribution between distance and near. So by reducing the step width, we can increase the add power of a multifocal lens. And by increasing the height of the diffraction grating, more light can be dedicated to near compared to distance. So when light passes through a diffraction grating, most of the light goes undeviated, which is called zero order diffraction. This light is used for distance vision. And majority of the other part light gets deviated by an angle theta, which is called first order diffraction. This is used for near vision. And in addition to this first order diffraction, there are various other orders of diffraction which gets deviated more than angle theta, which are actually not used for vision and hence considered as lost energy in diffractive lenses. Among the various diffraction grating designs, H-slit grating is of particular interest because it has an optimal blaze angle, which is the angle between the lens surface and the diffraction grating surface, which when optimized gives more energy distribution to the higher order diffraction. So this technology is particularly used in symphony lenses, which is a lens by Johnson and Johnson. Working distance for routine tasks needs a working distance of 40 to 80 centimeters. Hence, the current multifocal lenses with bifocal technology may not suffice the need. So then there came the trifocal technology. Trifocal lenses are made by combining two diffractive structures of two different ads, resulting in three foci. Then came the quadrifocal technology. In contrast to trifocal technology, which has focus for distance 80 centimeter and 40 centimeter, quadrifocal technology has focus for distance 120, 60, and 40 centimeters. However, 120 centimeter focus is deviated to the distance to give a better distance vision. And now the intermediate focus is at 6 centimeters instead of 80 centimeters, which is more comfortable for routine work. Then comes the wavefront technology. Here, there is a positive spherical aberration which is induced in the center, surrounded by a negative spherical aberration in the mid-periphery, followed by a peripheral aspheric zone. This gives a, a good intermediate vision and hence used in EDOF lenses like mini-well lenses. The other wavefront technology is a smooth transition of power from periphery to the center, which is used in Techni's eye-enhanced lenses. The intermediate vision given by this lens is moderate and is at a much higher distance than mini-well lenses. EDOF multifocal combination technology is a breakthrough technology. Here, multifocal and diffractive multifocal and diffractive EDOF lens technology is combined. That is, a Technis multifocal and Technis Symphony is combined to get a synergy lens. Here, there is a focus for distance, intermediate, and near. And in addition to this, the Johnson & Johnson has a technology of achromatic lenses, which reduces the chromatic aberration and hence gives a better quality of vision. So how do we choose the right presbyopic lenses? It again depends on the patient requirement and patient expectation, also on the affordability and eye characteristics. So the first thing is to identify the patient's requirement and expectation. So first we should know what are the routine activities, both outdoor and indoor, working distance for reading, and does he have to drive in the, after the evening, the current refractive status, whether he's myope, hyperope, or emetrope, does he consider need of glasses as a failure, or are some halos acceptable to the patient after surgery? So once we assess the patient requirement, we know that multifocal lens gives distance and near vision, EDOF lenses gives distance and intermediate vision, and trifocal lenses gives vision for all the three distances. However, we need to address the patient's expectation before we counsel the patient for presbyopic lenses. If the patient's need for reading, if the patient thinks that need for reading glasses is considered as failure of presbyopic lens, or if he's habitually reads at a closer distance, as in myopes, or need to read at lower illumination is required, then consider multifocal IOLs with higher rad. If the patient is needs to frequently drive after it becomes dark, and some degree of halos around a point source of light is considered as completely unacceptable, then either put monofocals or non-diffractive EDOF lenses. Depending on the scotopic pupil size, if it is a small pupil with a distance priority, then consider monofocals, and no multifocals would be suited for these patients. If the pupil is large and he needs a distance priority, then consider trifocal or epidermis multifocals. If he has a near priority, again consider multifocal IOLs with higher rads. Visual angle is important in planning presbyopic lenses. Angle alpha is the angle between visual axis and the optical axis. Angle kappa is the angle between pupillary axis and the visual axis. If the patient has a large angle kappa, then consider a lens which has got a highest central zone diameter, as in Panoptix and Symphony. If the patient has got a large angle alpha, then better to avoid it's better to avoid multifocals and consider monofocals. In addition, if the patient has dry eye, irregular cornea, zonular weakness or mild subluxation, glaucomatous disease, or macular disease, then it is better to avoid presbyopic lenses. Preoperative evaluation includes dry eye evaluation, macular evaluation including OCT, potential acuity meter, topography. This helps in ruling out unsuitable cases for presbyopic lenses. In addition, good optical biometry and image-guided system, especially in case of multifocal toric lenses, would help in improve the results. Two things can destroy any relation: unrealistic expectation and poor communication. So exchange of information is important. The education regarding halos, glare, and starburst before the patient goes for a surgery is important. Finally, we need to balance between spectacle dependence and certain photic phenomena. Although the photic phenomena are much lesser with newer lenses, it is still there in most of the diffractive lenses. So good communication, good patient selection, and good IOL selection helps in getting a better, happy patient and a happy doctor. Thank you.
Thank you so much, Vijay. Very nicely dealt with a relatively difficult